everyone. I'm Molly Lindquist, part of the Manta Cares team, and I want to welcome you to our Patient from Hell podcast club. The purpose of the Patient from Hell PCORI episodes, funded by the Patient-Centered Outcomes Research Institute, is to bring PCORI-funded researchers onto the podcast to share about their research so more of us can learn about it and use it to help us in our own lives as patients or care partners. And the podcast club gives us the opportunity to chat with members of our community to get their thoughts on each episode. Today, I'm really excited to chat with Anjali Vasavada about her work as a PhD candidate in epidemiology and her interest in improving adherence to lung cancer screening for patients and families. We're also going to get her thoughts on episode 60 of the Patient from Hell podcast, Does Frequent Surveillance Improve Lung Cancer Patient Outcomes? With Dr. Benjamin Kozower. Anjali, thank you so much for being here. I'd love for you to start by maybe explaining a day in the life of a PhD candidate and the work that you're doing in oncology.
Yeah, so the day in the life is kind of variable day by day. The great part about being a PhD student is that you really get to hone in on these research skills that, you don't get to explore in an otherwise workplace setting. My interests have always been making cancer screening more patient-centered and patient-focused. I am really passionate about using digital health and other types of technology to make screening more accessible for patients, because I think that's kind of where the future of cancer screening is going, especially with the rise in use of patient portal messaging. Oftentimes, patients spend more time talking to their doctor on the EHR than face-to-face. So I'm really passionate about how we can improve those things, how we can identify disparities in who has access to the patient portal, right? And how we can target interventions to those people specifically. So I would highly recommend, if anybody is watching this podcast club and is interested or on the fence of applying to graduate school to get a PhD, just go for it. I think it's a great experience. You get to really tap into parts of your brain that you didn't know existed. So, yeah.
That's amazing. Just one follow-up question for you is, how did you kind of land in the world of epidemiology and specifically kind of the improvements in the patient-centered experience for screening?
Yeah. So prior to coming to graduate school, I was working at Dana-Farber Cancer Institute in Boston. There, I was just a clinical research coordinator, which kind of was the only job that I could get right out of school. But it gave me a really valuable opportunity to spend face-to-face time with patients. I spent a lot of time talking to patients and their families as they were going through these complex experimental treatments. And that made me realize that there's kind of a disconnect in the language between patients and providers. And it kind of just sparked my curiosity of how can we make the health system more intuitive to patients, and how can we bridge that gap, especially because sometimes it feels like there are two different languages that are being spoken, and there is such a great opportunity to leverage tools to make that communication easier. So that kind of is where I started to get interested in these patient-centered interventions. And then my foray into epidemiology kind of just happened naturally after that. I knew I wanted to do public health. I knew I wanted to be involved in the healthcare system. And one thing that I really enjoy about research is trying to craft research questions and research methods that are appropriate for that question. And you learn that in epidemiology. You learn how to create a study. You learn how to do analysis to get the appropriate results that you are looking for. So I think it was kind of every little pathway kind of led me to where I am now.
I love that. It's so interesting how life works that way. So now actually let's transition into speaking about the PCORI episode, episode 60, Does Frequent Surveillance Improve Lung Cancer Patient Outcomes? That study was done by Dr. Kozower. Do you have any kind of initial thoughts on the episode?
Yeah, I thought it was a really interesting episode. Like we talked about a little bit earlier, I do focus on lung cancer screening, specifically in my research. So it was cool to learn about, because I think when we talk about surveillance, we often think oh, screening and surveillance are the same. And me being part of that world, I went into it being oh yeah, surveillance, screening, they use the same thing. But it was actually really informative for me as somebody who's still growing in my understanding of this world that, surveillance and screening are completely different. They have different purposes. And even if they use similar tests, the utility of them is just different. So that was the first thing that I really took away from it. I was also really intrigued by the results of the study, where they found that more aggressive surveillance does not necessarily indicate like better survival rates. Granted, it was a retrospective study, and like obviously there are some biases in interpreting those results. I still thought it was like really valuable to know all those things. So those are my main takeaways. I have a lot of thoughts, but I'm open to hearing what you have to say too.
Yes. Well, actually, the results are something I wanted to dig into a little bit more, because I think from a patient standpoint, that can be really disconcerting, just because I think the general kind of psychological piece is that the more you're looking for things, the more likely you are to catch them. How do you kind of integrate that view? Particularly, I know, given your work is all about communicating in a way that's, more universally understandable. Any thoughts on that?
Yeah, I think like I know with the population that is doing surveillance for any type of cancer, there's a level of anxiety, right? There's a lot of fear going in that you want to get these like repeated scans to make sure nothing's wrong, right? I think what's important from a messaging standpoint is for physicians to kind of lay out like, hey, like now that you are, clinically cancer free, your surveillance will look like this. There's nothing to be worried about. This is based on research that has been done, that like we have assured from a research perspective that your chances of survival are not any different if you come in 3 times a month or 3 times a year, sorry, every 3 months, or like every 6 months. You know what I mean? So I think it's really important for physicians to communicate that, but also have that communication in different platforms too, right? Like I think patients in today's day and age, we do rely on the internet a lot for getting our immediate sources of information. I think like the last time I read this, it was like 90% of patients, the first line of information is the internet. So could we leverage, if we're thinking about lung cancer screening specifically, could we leverage like the American Lung Association? Their website is really informative. Could we have that same information on that, saying that this is what surveillance will look like? You know what I mean? So I think that's a really important thing. It's like, yes, physician communication is important, but how can we, plug communication about what surveillance looks like in different platforms?
Absolutely. In the work that you've done with lung cancer specifically, how does stigma kind of factor in both from a screening and surveillance from your perspective?
Yeah. I was hoping you'd ask me that question, because one of my dissertation aims is actually looking at self-reported stigma and how that influences uptake of screening. I think there is a lot of talk about stigma when it comes to the lung cancer screening population, given that, tobacco use is something that is highly stigmatized in our society. In speaking to patients, directly one-on-one in like qualitative interviews that I've been doing, I've noticed that it comes up a lot with patients talking to their providers, feeling like this provider is judging them for smoking, right? So I think one big thing when it comes to the stigma in this population is how we can reframe our communication and messaging to be more empathetic to current or previous tobacco users, especially in this population who's a little bit older. Like using tobacco was really common, like in the 70s, 80s, right? It was plastered everywhere. People thought it would make you skinny, right? And like, if we really think about it, the culprit here is like big advertising and tobacco advertising. So it's not fair to place the blame individually on these patients for things that like it was socially accepted, right? We might find like in 20 years from now, like using social media, does stuff like that. But that's just a facet of our time, right? So similarly, tobacco use was a facet of that time. So I think it's really important to reframe messaging to not make tobacco use or tobacco history like an individual fault of a patient, right? And instead reframe it as like, this is just something because of your tobacco use, you might consider this, instead of saying you should quit smoking. You know what I mean? So, how can we have these conversations that are still productive for the patient to maybe, stop using tobacco, but without like, initially, villainizing them? for using
Right.
tobacco in the first place. So, yeah.
Makes sense. That makes complete sense. Any other parts of the podcast that particularly resonated with you or gave you questions?
Yeah, no, I thought there's like a lot of really interesting stuff and little tidbits that I learned about, lung cancer etiology as well, which I was like, whoa, I should really read up on this. But, what I really kind of stuck with was that like early intervention, early screening is so important because the earlier you screen, the more likely you are to identify any nodule or any precancerous nodule or stage 1 nodule early, which means early intervention, early treatment, and higher rates of survival. So it's like the main takeaway for me was like, now that there isn't an accepted and adapted way of screening with a low dose CT every year for people who have the history, the 20-pack-year history, and fall in that range, keep getting screened. It's covered by Medicare. Just do it. It'll be good for you in the future. So that was like kind of my main takeaway is like, it all starts from the beginning, right? So how can we make sure that people get in the beginning?
Yep, that makes complete sense. Anjali, thank you so much for being a part of our podcast club, sharing your insights. And of course, we wish you the best of luck on the rest of your PhD journey. Again, thank you for the great recap of Dr. Kozower's episode. And we look forward to our next podcast club soon.
Yeah, thanks for having me.